So good afternoon again. Today I am going to discuss the inguinal hernia surgery, especially TAPP, Transabdominal Preperitoneal Hernia surgery, how to perform by laparoscopy. And this you will practice also during the last day of your dissection in our animal lab in the United States of America. There are only few animal lab which has a license to perform. So that's why we are here, and last day will be your anesthetized animal lab. You will do hernia, cholecystectomy, duodenal perforation, all the surgery yourself. So we are starting with the inguinal hernia surgery. Hernia is a very common problem in the day-to-day practice of the surgeon, and it is a routine surgery which is performed by every surgeon in their practice. So it is called price being paid by mankind for the erect posture, because inguinal hernia is the most common and it is due to the erect posture, because it is not there in the animal, but once the human become erect, internal and external ring is in the same line and hernia happens. It was started long back, but first in 19th century, Eduardo Bassini has given the good Italian surgery that is called Bassini repair. Then in 1983, tension-free repair was given by Estopa with the Estopa peritalization technique. And in 1987, Gare has performed the first laparoscopic hernia repair. Classification you already know. Hernia classification is according to site, according to occurrence and clinical. Site may be epigastric, may be sphlegian, may be umbilical, may be suprapubic or incisional, may be inguinal or may be femoral. And occurrence is primary, recurrent and incisional, and clinically it is divided into reducible, irreducible, obstructed and strangulated. Treatment of hernia is as old as history of medicine. In old time, people were using these type of metal truss. Right now also, some company they make this type of metal truss, but it is seldom indicated. Surgery is the only option, either open or laparoscopy. In laparoscopy, two good options are there, that is totally extraperitoneal and transabdominal preperitoneal. IPOM also can be done for inguinal hernia, but it is less popular. Mostly it is TAPP which is more popular, because TAPP you can do any type of hernia. TAPP and TAPP. In TAPP you will not enter into abdominal cavity, you will go to preperitoneal and then you will put the mesh. So you are not cutting the peritoneum and you don't have to suture either. In TAPP, first you will enter into abdominal cavity and you will give incision over the peritoneum and then you will put the mesh. But mesh is covered by peritoneum in both the surgery. Hernia surgery give you Pascal principle of hydrostatic pressure. That's why it is considered better. Suppose you have a bathtub and you want to put a stopper of a bathtub, always you will like to put it from inside. If you will put it from outside, it may dislodge. So in laparoscopy, we put the mesh from inside, and that's why it is considered better. Suppose this is the defect and this is the visceral pressure. So in laparoscopy, we put it from inside, but in open, you put from outside. If you put from outside, there is a chance that it can dislodge. But if you put from inside, it is fixed. It won't dislodge. So this is in favor of Pascal principle of hydrostatic pressure. Laparoscopic hernia is a very old surgery, but in the much older time, it was not considered as a method of choice. First big study was in British Medical Journal in 2003. That was a 5-year randomized controlled trial. in which they say open herniorrhaphy has more complication than laparoscopy. So this was the first publication in which they proved open bad, laparoscopy better. And after that many publication has come which is saying that laparoscopy is better. What is the advantage? First advantage you have that it is a tension-free repair. So you can entire myopectoneal orifice you can cover with the mesh. Less tissue dissection and disruption, less pain, low complication and early return to work. All the authors, all the books are confirm that for bilateral and recurrent hernia, laparoscopy is considered gold standard. Because it is easy to perform with a single mesh, you can repair either side. And in recurrent hernia, if you will again do open, again recurrent chance is high. So laparoscopy is better. But for multiple hernia, femoral hernia, primary inguinal hernia, laparoscopy is also good, open is also good. There are few contraindications. Massive scrotal hernia you should avoid. Non-irreducible incarcerated inguinal hernia you should avoid. If prior laparoscopic hernia is performed and it's a failure, you should avoid. If prior pelvic lymph node dissection due to any cancer, lymph node dissection around the iliac vessel, you should avoid. And there is a prior groin irradiation due to any cancer, groin irradiation, you should avoid, because those areas will have dense adhesion and fibrosis. So that's why you should avoid in these cases. SAGE's recommendation is Society of American Gastrointestinal Endoscopic Surgeon. They recommend that if patient is fit for GA and hernia is bilateral and recurrent, laparoscopy is gold standard. For unilateral, plus minus, it is do good or bad. Strangulated, minus minus. You will never do laparoscopy, you will do open. If patient is unfit for GA, then under a spinal you can do, but only for a small hernia. Large hernia under a spinal you should prefer open. And there is no role of laparoscopy hernia surgery under local anesthesia. For that always you should go open. So this is how you will do patient selection. Before starting the hernia surgery, you should try to look for 9 important landmarks, and those are called compass of the pelvis. 9 important. What are those? 3 false ligament, 3 true ligament and 3 dangerous area. First false ligament is median umbilical ligament. Median. That is obliterated urachus. That always you should see. Then there are 2 medial. This is called medial. This is one medial, this is another medial. And these are medial umbilical ligament. These are 2. This is one, this is second. And why it is important? That bladder is in between these 2 medial umbilical ligament. And you should never give any sharp dissection medial to medial umbilical ligament, otherwise you will perforate the bladder. So if you want to reflect the bladder, always do blunt dissection. Otherwise you will, if you will cut it sharp by the harmonic or by the scissors, you will perforate the bladder. And this is the importance of medial umbilical ligament. Then you have a lateral umbilical ligament, that is inferior epigastric vessel. Lateral umbilical ligament is the key landmark for classification of hernia. If hernia is lateral to lateral umbilical ligament, this will be indirect. If it is medial, then it is direct. And if it is below the inguinal and medial, then it will be, here will be femoral. And deep down there will be obturator. So inferior epigastric is a landmark. After that, these are three false ligaments because it looks like ligament, but it is actually not ligament. Now you have three true ligament. This is the first true ligament, that is inguinal ligament. This is the inguinal ligament. Then you have a second true ligament, that is Cooper ligament, that is also called iliopectineal ligament, also called lighthouse because it reflects light. And this is lacunar ligament. Lacunar ligament is joining the inguinal with the Cooper. So these are the three true ligaments which you should see. After that, there are three dangerous areas. First dangerous area is triangle of doom. Doom word means impending death. Apex of the triangle of doom is deep ring. Medially, there will be vast difference in the male and round ligament in the female. Laterally, there will be a spermatic vessel or gonadal vessel, whatever you say, or testicular vessel, the same name. Why it is called triangle of doom? Because if your hook is piercing or scissors has injured the iliac vessel, there may be death on the table. So that's why we should always do blunt dissection in this area. Any sharp instrument should not be taken. After that, this is called triangle of pain. Apex is again deep ring. Laterally you have inguinal ligament, and medially you have a spermatic vessel. And this has two nerves. One is GFN. This is medially placed GFN. GFN is genital branch of genitofemoral nerve. And another is LFCN, that is lateral femoral cutaneous nerve of thigh. So you should never fire your tacker here, or don't use much energy here. If LFCN will be injured, then patient will have hyperesthesia and paraesthesia of the skin of the lateral upper thigh and skin around the hip joint. And if you will injure the GFN, then hyperesthesia and paraesthesia of the skin of the scrotum. So that's why it is called triangle of pain. This is called triangle of pain. So if you do something wrong, there will be pain. And now here is called trapezoid of disaster. Actually, in some of the book, upper portion of the trapezoid includes the triangle of doom also. But actually, this is trapezoid where you have corona mortis vein and aberrant obturator vessel. And if you will do something wrong here, these vessels can be injured and there will be huge hematoma. That's why it's called trapezoid of disaster. Aberrant obturator vessel is joining the inferior epigastric vessel with the obturator vessel. So again, this is median umbilical ligament. This is medial umbilical ligament. And this is lateral umbilical ligament. This is urachus. This is obliterated umbilical artery, and this is inferior epigastric vessel. This is triangle of doom. This is triangle of pain, and this is trapezoid of disaster. Here is the aberrant obturator vessel and corona mortis vein. If hernia is here, this will be indirect. If it is here, this will be direct. If it is here, this will be femoral. And if it is here, this will be obturator. So this is very easy. This is the triangle of pain. and this is triangle of doom. In hernia, what we do? We reflect the peritoneum and we cover the entire myopectoral orifice with the mesh. You have to take care of three important points. One is that size of the mesh. Size of mesh should be 10 plus defect minimum or 12 plus defect maximum. Like suppose you have a 3 centimeter defect, then size should be 15 by 15. This is first. Bigger size is better, because at the end of 1 year mesh shrinks. Some mesh shrink up to 40%, megapore mesh. So you should try to use bigger mesh. Another, center of the mesh must be in the center of defect. Suppose this is hernia and I will put the mesh like that, there will be recurrence, because once the mesh will shrink, there will be recurrence. Or if this is the hernia and I will put the mesh like that, there will be 100% recurrence. That's why in case of direct hernia, mesh may go to opposite side also. So that center of the mesh should be center of defect. And the third important point, that minimum tacker should be used. More tacker should not be used. So suppose this is indirect hernia, then one tacker over the Cooper and other extreme lateral, that's all. You should not use multiple tackers. Anyway, this area you cannot apply tacker, this area you cannot apply tacker, this area you cannot apply tacker. But if you will use more tacker, patient will have more pain. There are many studies published in which they say no fixation is better than fixation. And fixation doesn't increase the recurrence chances. Means if you don't fix it, then also recurrence will be same, and if you fix it, then also recurrence will be same. So fixation should be avoided, and if you fix it, maximum 2. And then closure of peritoneum either by suturing or by tacker. This is a 3-dimensional view to show how inferior epigastric vessel originate from the iliac vessel. This is just a sketch. This is inguinal ligament. This is inferior epigastric vessel. This is vas, and this is spermatic vessel. If hernia is there, it is indirect, here direct, and here femoral. This is triangle of doom. This is right side hernia. This is triangle of pain, and here is the trapezoid of disaster. You can see in the triangle of pain you have two nerves, LFCN and GFN. And in triangle of doom you have the iliac artery, iliac vein. And in trapezoid of disaster you have the aberrant obturator vessel. So always these important landmarks should be kept in mind. This is again just to orient you left side. This is median umbilical ligament. This is medial umbilical ligament. This is lateral umbilical ligament. These are the 3 false ligament, false ligament. This is inguinal ligament. This is Cooper ligament, and here is the lacunar ligament. These are true ligament. And this is triangle of doom. This is triangle of pain, and this is trapezoid of disaster. If hernia is there, it will be indirect. This is indirect. If hernia is here, it is direct. And if hernia is here, it is femoral. This is femoral, you can see it is written. And if hernia is there, this will be obturator. This is bladder. Here is the pubic symphysis. This is medial umbilical ligament. This is deep ring. This is vas deferens. This is spermatic vessel. This is triangle of doom. This is triangle of pain. And this is bowel. But in this patient, there is no hernia. Hernia you cannot hide in laparoscopy. As soon as you create pneumoperitoneum, it will show as a black hole. And you cannot hide it. Black hole. This is which hernia? Indirect. This is direct. And this is femoral. So it is very easy to classify. This is sliding hernia. This is pantaloon hernia, where indirect and direct both is there. This is triangle of doom. This is triangle of pain. This is bladder. So this is pantaloon hernia, left side. So you will open the peritoneum, make a pocket all around, put a mesh, and this is bad. Why? Over fixation. This is bad and this is good. Over fixation must be avoided. Choice of mesh in TAPP Transabdominal Preperitoneal. You should not spend your money to buy the expensive mesh. You don't need proceed mesh, you don't need auto fixating mesh, you don't need 3D mesh, you don't need titanium mesh, you don't need Gore-Tex, or these meshes are not required. You should use simple polypropylene mesh. Why? Ultimately it is going to be covered by the peritoneum, and healthy peritoneum is the best known adhesive barrier. So once you cover by the peritoneum, you don't need expensive mesh. You will identify the hernia. After that, you will start giving incision. Where you will stand? You will stand opposite to the pathology. Suppose hernia is right side, you should stand near the left shoulder. This is surgeon, and monitor should be in such a way that you should have a coaxial alignment. Distance of the monitor should be 5 times to the diagonal length of the screen. If 14-inch screen, 70 inch away, 21-inch screen, 105 inch away. One assistant opposite side and a scrub nurse will be left to you. So this is the position of surgical team. Port position may be contralateral, may be ipsilateral. You can put the port in umbilicus, and one port 7.5 and one port 7.5. Here is the hernia. And you will stand here and monitor will be here, so that you have a coaxial alignment to perform the surgery. But ipsilateral is also possible. How? You will put a supraumbilical port and one port 7.5 and other 7.5. So telescope will be here and these two ports will be like that. This is called ipsilateral, and this one right now is contralateral. So this is the how you will put. If right side hernia, this is the port. Left side hernia, this is the port. If it is bilateral hernia, all the 3 ports should be in the same line, so that you can do both the hernia. But if you have to do right side, you will go here, left side, and right side you will go here. And with these 3 ports, you can do either side of the hernia. So in bilateral, all the 3 ports should be in the same line. You will open the peritoneum 6 centimeter lateral to the outer margin of defect, and most of the time it comes at the anterior superior iliac spine. and after that you will come up to the medial umbilical ligament. So you will start and come up to medial umbilical ligament. Once you come up to medial umbilical ligament, after that first you do lateral dissection, then medial dissection, and then do sac dissection. Don't jump on the sac directly. You should first make triangle of pain, then go to trapezoid of disaster, and then go to triangle of doom. Directly jumping to the sac, you will make a lot of buttonhole and you may start bleeding. So first lateral, medial, and then sac dissection should be done. And then you will see that peritoneum is separated, and what you are seeing right now in front is hernia. The sac is taken out and transversalis fascia will be visible. This is inferior epigastric vessel, this is vas, and this is a spermatic vessel, and this is a direct hernia. So at the end of the surgery, you will see that directly this black hole with the transversalis fascia will be visible. If the sac is very big, you can tie a knot and you can cut it away. But remember, you have to cut here. That area which is going in inguinal canal should be open, otherwise hydrocele can form. And once you put a mesh, then you fix it either by tacker or by suturing. Tacker will be easy. Tacker you can use. Here we can see that this is the tacker. Every company is making this tacker, and this is Pro Tack from Covidian, and it has a 30 tacker loaded. So suppose this is the hernia and here is the mesh. You will put the mesh over that and then you will fire. So I am demonstrating you here, or here this is the mesh and you will fire. And you can see here this is fixed. And this tacker is titanium, so it doesn't react with the human body. Absorbable tackers are also available. Depending upon your choice, you may use absorbable tacker, and that is possible. So these are tackers which is fired. Alternatively, you can use continuous suturing, Dundee jamming knot, continuous suturing, and Aberdeen termination. And now the peritoneum is approximated together. During firing the tacker of the peritoneum or suturing, you should reduce the pressure to 8 millimeter of mercury, so that there will be no tearing of the peritoneum. You should reduce the pneumoperitoneum pressure. So we will see how to do the surgery. Here I am going to demonstrate you a skin to a skin entire surgery of the left sided inguinal hernia, and here we will perform by the ipsilateral port. So ipsilateral port has advantage that your arm will not be abducted, but it can only be performed for the one-sided hernia. This is the hernia here. This patient has open surgery for the right side before. So this is the hernia, and we will see how to do. You will put a thumb like that, and your port should be supraumbilical. And then this is the previous hernia scar. So camera will be supraumbilical. In contralateral, you may put in umbilicus, but for ipsilateral, supraumbilical is better. And this arc is 18 centimeter. So your one port will be here. This is your left hand, and one port will be here. This is your right hand. These are the 3 ports, and in ipsilateral your manipulation angle will be 30° only. In contralateral your manipulation angle will be 60°. So that's why contralateral is better. But if it is one-sided hernia, you may do ipsilateral. So first you will put Veress needle. This is the Veress needle, how you will put it. And then irrigation, suction and hanging drop test. This is hanging drop, it is sucking in. This is good to know that you are abdominal cavity inside. Then attach, and we can see preset pressure is 15, and within first 5 seconds your actual pressure should be single digit. It should be single digit. And up to 1 liter your flow rate should be 1, because if it is going in vein there may be air embolism. But once 1 liter gas is gone, then you may increase to 3. However, more than 2.5 liter will not go with the eye of the Veress needle. So Veress needle is over. After that you will enlarge the incision and put the first port, that is optical port. So this is optical port which is introduced. And then you will attach the tubing of insufflator, and then put the telescope, and under vision of the telescope you will put 2 other ports. First you will do diagnostic and then you will put 2 other ports. Now the OT light should be dimmed, and most of the time you can see the trans illumination light also can be visualized. Distance from hernia, it should be 18 centimeter, because your instrument length is 36 centimeter, and from here also it should be 18 centimeter. This is 18, this is 18 centimeter. This is 24 centimeter. Now head should be down and left should be up. Head down and left up. You should ask your anesthetist. And now OT light is dim. You can see trans illumination. There is a light is visible here of the telescope. And then you will start performing the surgery. We can see here, this is an indirect hernia. This is median. This is median umbilical ligament. This is medial. And this is lateral. Here is the hernia. Because it is lateral to inferior epigastric, so that's why it is indirect hernia. If you are doing by ipsilateral port and you are on the standing on the right side, then you should start from the medial umbilical ligament and go up to the 6 centimeter lateral to the outer margin of defect, probably up to the anterior superior iliac spine. So you will start, but never cut medial to medial umbilical ligament. So if you are right handed, you should start your incision from here and then go like that. If you are left handed, then go like this for left side. And for right side, right handed should go lateral to medial and left handed should go medial to lateral. And on left side, right handed should go medial to lateral, left handed should go lateral to medial. And this is a harmonic Once you are cutting the peritoneum, left hand should stretch the peritoneum down and take care of this inferior epigastric vessel. So you should reflect the peritoneum and push the inferior epigastric vessel away to the abdominal wall. You can see here inferior epigastric vessel has gone, and now keep on cutting. This is the inferior epigastric vessel. This is the inferior epigastric here. And then you keep on cutting. Outer margin 1, 2, 3, 4, 5, 6, up to 6 centimeter lateral, and then you can come little down. After that you will start. Remember, in hernia surgery, after cutting the peritoneum, you don't need any energy. You can perform the entire hernia surgery with the 2 atraumatic grasper. You don't need any scissors, any hook, any harmonic, any ligature. So we can see these are 2 grasper, and this is the lateral window, lateral peritoneal dissection. And always remember, in the laparoscopy, there is a rule that fat belongs to organ. Always, fat belongs to organ. Like fat, if you are separating bladder, leave the fat towards the bladder. If you are separating rectum, leave the fat towards the rectum. And here also try to leave the fat towards the abdominal wall. Then there will be less pain also. So another important point in laparoscopy is always remember white is right. God has made our body in such a way that every 2 layers there is a areolar tissue. And those areolar tissue pain, facial plane. And fascia, there is no fibroblast, there is no, so you can easily, once harmonic vibrates, it breaks the hydrogen bond and you have a plane of dissection. So once you open the peritoneum, always take care that peritoneum should be separated bluntly, not use any energy. This is lateral dissection. And try to push the fat towards the abdominal wall. Lateral dissection is over. How you will know it is over? You will reach to the spermatic vessel. And left hand is stretching it down and right hand is making this pocket. Here is the adhesion of sigmoid. This is a sigmoid colon. What should I do? Nothing. Once you will separate, the sac automatically drop. You don't have to mobilize the sigmoid. Just keep on mobilizing your peritoneum. And sac should never be touched in the first instance. Now you will do medial dissection. And in medial dissection, you have to medialize the bladder bluntly. You need to medialize the bladder bluntly. And as soon as you will go a little bit inferomedial, just by 2 grasper, no need of any energy. And here you will get Cooper ligament, that is called lighthouse. And this is the Cooper, which is exposed. This is called Cooper ligament. And that's why it is called lighthouse, because it reflects pearly white color light. That cannot be ignored. You have to see that. And then you will medialize the bladder further bluntly, all blunt. Don't use any sharp, otherwise you will perforate the bladder. Don't use hook, don't use harmonic, and this is a space of radius. So we can see this is inferior epigastric vessel, this is Cooper ligament, this is urinary bladder, and this is sigmoid colon. So this just medialization is required bluntly. So this is medial dissection. After lateral dissection, this is medial dissection. Here is a space of radius, all blunt. This is a space of radius, that is that is retropubic area, and bladder is medialized. After that, now you will do sac dissection, and you will pull the peritoneum down and push the transversalis fascia away. One thing is very important, that hernia, you should push it more rather than pulling. If you will try to forcefully pull this peritoneum will tear and a lot of buttonholes. So see, left hand is static and right is pushing away. More important is the right hand, who should push the transversalis fascia away. Always remain lateral to inferior epigastric vessel. This is the sac, because it is an indirect hernia. And very gently you should pull the peritoneum and push the vas and spermatic vessel away. This dissection is very important. This is a sac coming out. And you will push the transversalis fascia down back to the sac, back to the defect. So key, this is the transversalis fascia here. This is also called pseudo sac. Beginners, they create problem because they cannot recognize pseudo sac from sac, and this is pushing back. So you should time to time lift the peritoneum and you should see this puckering. If this puckering is present, that means your sac dissection is still not complete. It should become like that. It should pouch out. What is this? This is the sigmoid adhesion. This you should ignore. This is not a problem. Problem is here, that this sac is still not out. So it should be completely out. And you should always remain towards the peritoneum and push the transversalis fascia away. This is the trick, that left hand should support and right should push away. And the pseudo sac will be pearly white color. Peritoneum will not be pearly white. And that should be gently pushed back to the defect. And it's gone. So it is very important that in hernia surgery, you should differentiate between the peritoneum and this pseudo sac. Time to time, if you have any doubt, just leave it and hold it again. It's done. Sac is out. After that, still our dissection is not complete, because you should completely see the triangle of doom. Suppose you have done that much only dissection and you will put a mesh, like I have put a mesh like that, then there will be 100% recurrence. If I will put a mesh like this, and then I will move this peritoneum up to suture, mesh will be displaced. So you must have either side, this side 5 centimeter, this side 5 centimeter, and down also this triangle of doom should be clear cut visible. So you will keep on still separating the peritoneum from vas and spermatic vessel. You can see here, this is your peritoneum, and these are the cord structure which you will separate. Here how you will stand to the opposite, and slowly you will start separating. You can see this is peritoneum, and you will keep on pushing. The vast difference will be medial and spermatic vessel will be lateral. You can see it now. Triangle of doom is visible. This is your peritoneum, and this is the edge of the peritoneum. You have a lot of peritoneum, and this is vas, this is a spermatic vessel, and this is inferior epigastric vessel. So basically it make a Mercedes sign, just like a Mercedes car. Mercedes car has a star like that. This is a star of the Mercedes car. So same way you will see, here will be the vas, this will be the spermatic vessel or gonadal vessel or testicular vessel, whatever you tell, and this is inferior epigastric vessel. So this, and this is the reflected peritoneum. These are the knobs. You can see this is GFN, this is LFCN. This is triangle of pain, this is triangle of doom, this is trapezoid of disaster. So peritoneum is separating from vas and spermatic vessel. This is a spermatic vessel, this is peritoneum, and you will push the spermatic vessel away to make a big pocket. Most of the people, they don't do this dissection, they leave it as it is and recurrence happen. Because when they go down, they become afraid seeing the iliac vessel. They don't want to, do that. And this is vas, and this peritoneum is separating. This is peritoneum. Here, this edge, this is peritoneum. This is the vas. So this edge should be held. You need a eagle eye to do hernia surgery. Anatomy is the most important. Anatomy. All the laparoscopy anatomy is different than the open surgery. And it's done, almost over. This is again vas. And now this is clear. You can see this is triangle of pain. This is triangle of doom. This is Cooper ligament. This is space of radius. Here is the bladder. Surgery over. It's finished. All around dissection is over. After that, just this is the iliac vessel. This is iliac vessel in between. This is the spermatic vessel. This is the vas. And here you can see pulsation of the iliac vessel, this one. This is external iliac artery. And vein will be medial, artery will be lateral. This is artery. And here will be vein. Vein is more dangerous. Artery is less dangerous because it is muscular and thick. Vein can be injured much easily. And vein is medial. So this is the triangle of doom. Here is the vas and this is a spermatic vessel. So now surgery is over. Dissection part is complete, and then you will put a mesh. This is the peritoneum. If you want, you can separate little more down here. This is pulling down. Why? Bigger pocket, better surgery. Patience is required. You should not be in hurry to complete surgery. Sometimes we have palpitation by seeing iliac vessel and you say that enough is enough, now it's over, now put it. Keep little patience. It is not a difficult surgery. Anatomy, once you have a good, you can perform hernia surgery very nicely. This is the space of radius. Here below will be the tendinous arc of levator and eye muscle. This is just for demonstration. You don't need to go in this area. Just we are demonstrating. If aberrant obturator vessel is there, it will be here. But it is aberrant, it is not always present. This is vas. This is a spermatic vessel, this is the inferior epigastric vessel, and this is the iliac vessel. These are the knobs. We can see this is triangle of pain, and these knobs are visible. If you see very carefully, this is the knob, which may be visible, may not be visible if the patient is obese. because we leave the fat towards that, so it may not be visible, it may be visible, that doesn't matter. So now it's over, and now this is a time to drop the mesh, and you will spread the mesh all around in this pocket. Try to make a pocket big, incision less. However, in the beginning you should try to make a big incision because making a pocket is difficult. This is the other side of medial umbilical ligament. This is other side of triangle of doom. But there is no hernia this side. This side hernia already operated before by open. Now you will spread the mesh, and infero-medial end of the mesh should go to the Cooper ligament and push the mesh in the pocket. Make it sure that center of the mesh should be in the center of defect. So here is a defect, and all around 5 centimeter mesh is projecting, center of the mesh in the center of defect. And then fire a tacker. First tacker you should fire over the Cooper. This is the Cooper. And you can see that through the mesh. But suppose it is not visible, then what to do? In that situation, you feel it, tactile feedback, and try to move the patient. If patient is moving, you are over the Cooper. If patient is not moving, that means you are either in the space of radius or upper. And sometimes, tacker induced hernia also happen if you will fire at wrong place. So then fire, and it's done. This is the tacker applied. One is enough, and another you should fire complete superolateral like this. You should never fire below inguinal ligament, that's all, it's enough. After that, we will decrease the pressure to 8 millimeter of mercury. And then you should lift the lower edge, and we will do double brass technique, just like the coat of double brass, and fire the tacker. But take care, this is inferior epigastric vessel. You should ideally be either medial or lateral. Never fire over inferior, hematoma will form. So this is always take care of this landmark. That's why I told you that 3 false ligament, 3 true ligament, and 3 dangerous area. So this is medial to the inferior epigastric vessel, fire the tacker. And now you can fire lateral to inferior epigastric vessel. And here is the inferior epigastric vessel, so be careful. And then this is lateral to inferior epigastric vessel, and the pressure is reduced. Now again, this is inferior epigastric here, this is the inferior epigastric vessel, and this is medial, this is lateral, not here. And it is fire. Here sigmoid colon is not necessary to do something, just you lift it and fire. These are the adhesions of sigmoid, that will not a problem. Right now patient is left up. Once patient becomes supine, then sigmoid also help you to press the mesh. And these adhesions of sigmoids are normal adhesion, you should not try to remove it. So it's over, and you have no peritoneum. Suppose a small buttonhole is there, once you reduce the gas, automatically this is medial to, this is inferior epigastric vessel, we can see, and this is medial to inferior epigastric vessel. You will fire, and it's done. Now slowly reduce the gas, and these are the adhesions of sigmoid, and here we have sigmoid, nothing is required, you don't need to touch it at all throughout the surgery. And once you will put the patient supine, right now patient head down, left up, then automatically it will press the mesh. And now slowly remove the mesh, remove the telescope, and slowly reduce the gas. So this is a very easy surgery if you take care of anatomy, and you can perform it only by two grasper. You don't need any hook, any scissors. I don't know why people are using hook or scissors to perform this surgery. You don't need it if you have a correct anatomy and correct orientation, and now it is done. So this way you can perform the inguinal hernia surgery. Now varicocelectomy also can be done just 2 centimeter below. You will cut the peritoneum, and you can see it is a blabbing, gas has entered inside. 2 centimeter below the deep ring, here is the iliac vessel. So always remain on the triangle of Doom, but lateral boundary of the triangle of Doom, and you will separate it, and then you will find out the vein by color. This is the blue color here, this is, you can see, this is the blue color, this blue color is a vein, this is blue color, and you will lift it, separate it, and coagulate it. Some people, they coagulate the vein and artery both, and nothing happens. There is no testicular atrophy. There is no decrease in the sperm count. There are literatures, you can find it in the Google, that artery and vein both, but why to do that? It is better to separate the artery from the vein and then coagulate it by the harmonic. So it is done. Now this is the harmonic scalpel. You coagulate it at two places and then cut. You may use ligashore also, there is no issue. So this is one side is cut, then other side also. So this is also very easy surgery. You don't need to close the peritoneum, and it is cut. If you want to take a biopsy, then you cut the medial side also and take a tissue for biopsy. Purpose of biopsy is not for malignancy here. Purpose of biopsy is that you can tell the, you have a report. So if recurrence happen, you can tell that I have done my job, histopathology is supporting. So this is over. So this is a very easy surgery which you can perform by laparoscopy. This is left side, majority of the, this is left only. Now complication. Immediate complication is visceral injury, vascular injury, injury to vas. Late complication is bowel adhesion to the mesh, intestinal obstruction, fistulization, orchitis, testicular atrophy, nerve entrapment, incisional hernia, and recurrence. This is a cartoon made by a general surgeon against laparoscopic surgeon. You are pumping the gas in the abdomen. Nurse is praying to God that save the triangle of doom, and animals are waiting for patient to die. So in old time, hernia surgery was not considered as a safe surgery, but now it is okay. Recurrence happened mostly because center of the mesh was not in the center of defect. This is a direct hernia, mesh would have been like that. But surgeon has put this mesh for indirect hernia. This mesh is good for indirect hernia, but this mesh is bad for direct hernia. So center of the mesh is not in the center of defect. This is very important. So recurrence. Another complication is overuse of excessive implant. You can see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16, 17, 18, 19, 20, 21, 22. So this is dangerous. You should not use those many tackers, and especially this is a bilateral hernia. In bilateral hernia, you don't need to fix the mesh at all. You can use a butterfly type of mesh, like a bow tie, and you can bring from one side to another, and that's all. Just close the peritoneum. In bilateral hernia, mesh is not going to go anywhere. A single 15 by 30 mesh can be used to reinforce the either side of myopectoneal orifice. So this is a problem. Other complication is if you will injure the iliac vessel, patient may die on the table, that is mortality. Inferior epigastric, iliopubic or spermatic vessel mostly create hematoma. Death is rare, not possible, but death can happen to anyone, but generally it create hematoma, infection, seroma, these things will happen. Seroma, if it happens, don't be in hurry to suck, but if infection continue, you should suck. Other complication is LFCN, nerve injury. Incidence is 2%. And it has two outcomes. If pain start days after surgery, like you did surgery today and patient has a pain after 5 days, don't worry. This is due to irritation of the nerve. This is LFCN, we can see this is LFCN and here will be GFN. This is LFCN and this is GFN. So if pain start days after surgery, don't worry, it will be recovered. Maximum you can give percutaneous steroid, but pain start within 24 hours surgery. Like you did surgery in the morning and afternoon or evening, patient is crying with the pain and hyperesthesia and paraesthesia of the upper aspect of the lateral upper thigh and skin around the hip joint, that means you have damaged this nerve. And there is no cure because it is a permanent nerve damage, and cryotherapy is required to destroy the sensory branch, and then lifelong numbness will be there. And that happens due to excessive use of scissors, hook, and pulling a lot of fat and these type of bad dissection. GFN injury is 1%, it is not much, but it only create hyperesthesia and paraesthesia of scrotum, but with time it subside with the time. Other complication is migration of mesh. There was a 6 centimeter hernia and you are using 6 centimeter mesh, and mesh will migrate in the scrotum. Patient will come after 1 week palpating the scrotum, what is this? Or it may migrate in the abdomen, because once you close the peritoneum, you have a lot of buttonholes. Rejection of mesh is rare, but over-blamed. Whenever we have infection, we say mesh is rejecting. And bowel adhesion happen, like suppose you have all the raw area, your peritoneum cannot be exposed, then bowel can adhere in this area. This is GFN, by the way. This is a spermatic vessel, this is GFN and this is LFCN. So bowel adhesion can happen if your pocket is not good and a lot of buttonholes are there. So these are the complications which we should keep in mind. So this was regarding the hernia surgery, where I have tried to make it faster, and just because of limited time, we try to discuss the different aspect of this. However, in your member area, there are 200 hernia surgery video. Pantaloon hernia, sliding hernia, bilateral hernia, and then all type of femoral hernia. So I will advise you just go through all the videos slowly. In the beginning, you should start your surgery of inguinal hernia with the small direct hernia, because in that removal of the sac is very easy, it comes out very easy. Don't take a big inguinoscrotal hernia. In the beginning, you should start with the direct hernia small, then indirect small, and then slowly take the difficult hernia cases. So thank you very much, Dr. Solomon. Thank you. Please tell. Yes.
¿Hay alguna pregunta? Is there any questions? Sí.
Sí, que cuando se pone la malla queda sobre los vasos. No importa.
No, así va a quedar.
O sea, no pasa nada.
No. So sí, lo que estás buscando es que cause una fibrosis y se detenga que se forme una cicatriz, y esa cicatriz va a ser la que va a impedir que se forme nuevamente la hernia. So the question was that you're going to put the mesh right on top of the iliac vessels, that if it doesn't cause a complication. So
Peritoneum is a very intelligent structure of the body. It knows where to press, where not to press. So even if we are covering not only iliac vessel, we are covering even vas or spermatic vessel also. But vas also doesn't create fibrosis. You know, in old time, people were cutting it and putting the mesh like that, isn't it? Dr. Solomon, you might have, you know that, like that. But now we cover everything. So it doesn't create any fibrosis over vas or spermatic vessel, and it doesn't create problem with the iliac vessel, because the inner side is peritoneum. So why it will push it? It will push the peritoneum down.
no. ¿Alguna otra pregunta, Doc? En español, lo que sea. Doctor, is there any questions that you might have, Dr. Sonar? No? No, I think everything is clear.
So
Sir.
thank you very much. I request you that please tomorrow make them perform hernia surgery. At least
Sure,
they can
sure.
put a mesh and suture it. So that will be easy for them to understand.
Yeah, sure.
Thank you very much.
Thank you, sir.
What
Thank
is
you.
the order from you for today?
Sir, we are finished today.
Thank
For
you.
you.
Thank
you, sir.
Thank you. Have a
Okay.
good day. Thank you very much.
Have a good day.
Thank you. Thank you.
Bye.